I hope my slides are visible right now.
Yes, sir.
I will make it full screen. Perfect. So as beautifully the background has been given for again the TNM 8th edition, the type 1, type 2, type 3 CVITs which we have is based on the cardiac location of the stomach, and a lot has changed into the molecular classification of the stomach cancer, as we see from the genomic atlas to the ACRCG subtypes. We have right now different.
So sorry to bother, but you need to run the slides. It's still at the slide 1.
Okay, so I will share it again. It happens. Is it fine?
It's hanged up now. Can you just scroll to the slide number 2, sir?
So if you can permit, I can share this.
Yeah, Aram, aap share. Okay. Yeah.
Perfect. So next slide, please. Yeah, so we have seen a lot of molecular classification being done for the stomach cancer from EBV type, where we have the PIK3CA mutation, this cycling D kinase 2A silencing, the JAK2 amplifications, and the PDL1, PDL2 amplifications, to the microsatellite instability, which forms the major 22% of the group, where we have the hypermutilation of the targetable oncoproteins, the genomic stable type, where we have the CDH1 mutations, which is mostly in the diffuse type of cancer, and in CIN, that is chromosomal instability type, where the RTK amplifications, the TP53 mutations, and the aneuploidy occurs. So the classification has been with us throughout. And what has the treatment significance? Next slide, please. So when we look at the standards across the peri-op chemos and the radiations, we look at the NCCN, the ESMO, the Japanese, and the Chinese society. Next slide, please. And all across, we feel that the peri-operative chemotherapy has been here to stay. So be it an operable also, even it's a T1, more than T1 lesions, the pre-operative chemotherapy in adenocarcinoma is there. Instead of going directly for the surgery, the preferred pathway is always the pre-operative systemic treatment. Next slide, please. In those with junctional CVIT 1 or 2 type, also the neoadjuvant chemotherapies, the perioperative chemotherapies is the preferred pathway, directly proceeding towards the surgery, because we know that it has a prognosis. Next. So the principle of neoadjuvant or the peri-op is that it increases the R0 resections, reduces the recurrence, reduces the metastasis, improves the survival, and it gives us in vivo sensitivity as how the patients are behaving with the indwelling chemotherapies inside, and also the compliance of the patient to the long-term treatment for it. The cons has been delaying the surgery, but again, that has been the only reason why the definitive treatment is there. But the perioperative chemotherapy serves as a stimulus test for most of the patients. The current standard is the FLOT, and we all are using it day in, day out for most of our patients, coming on from this Lancet study, which was published for the gastric and gastroesophageal cancers. For those who are technically operable, more than T1 lesions, any node positive, a very simple regimen that we use is docetaxel 50 milligram per meter square, 5-FU 2600 milligram per meter square, and oxaliplatin 85 milligram per meter square every 2 weekly. The current standards which were there, to which it was compared, was the ECF or the ECX regimen, And the stratification factors were on the base of the performance status, the location of the primary, age, and nodal status. Next slide, please. And all across, it was uniformly stratified population. So both of them were uniform characteristics across the age, sex, and the location type, and the nodal status, and the Lauren classification. Next slide, please. So you could see that the FLOT clearly outcast the current standard for it, which was the ECF or the ECX, with the median overall survival with 50 months with the FLOT survival, as compared to the ECX, where it was around 37 months with 23% reduced risk of deaths as compared when you give FLOT as compared to the ECF regimen. With a 5-year overall survival rate of 45%, it became a standard of treatment across. Next slide, please. And which subgroups it benefited, you could see that across all subgroups, it's had a uniform and relative effect, that the FLOT had a good hazard ratios across all the subgroups, be it a sex, be it age, be it any stratification factors, nodal, or the TNM staging. Everywhere the FLOT was uniform to stay with. Next slide, please. So the median DFS was also quite high. You could see that 25% reduced risk of events with a 5-year DFS of around 41% with FLOT. Next slide, please. It became the new standard for it. So FLOT increases the tumor surgeries, it increases the R0 resections, it included more negative nodal status, and it became the standard of treatment. Next slide, please. And for those who feel that FLOT can't be given in a remote setting or in a rural situations, 5% of the patients receive GCSF with the primary prophylaxis, and secondary prophylaxis 34% of them. With a tolerable neutropenia, side effects, I believe the treatment was there to stay. So 60% patients got FLOT in post-op, with 46% at the end of the day. Compliance means that half of your patients tend to complete those 8 chemo regimens which are planned for them. Next slide, please. So FLOT was the current standard. If not suitable, doublet was the treatment. So peri-op chemotherapy was there to stay. Next slide, please. Now, the other regimen, which was, I believe, primitive regimen, was a cross regimen for the Sieverts 1 and 2. Next slide, please. And in adjuvant also, when we do the standard treatment, because many of these patients in Asia was considered for an upfront resections before the perioperative chemotherapy became a standard. The role of immunotherapies was established by the Checkmate 577 trial. The Prodigy trial also showed the adjuvant chemotherapies. So only those patients who underwent radical gastrectomy without neoadjuvant therapy, more than 16 lymph nodes, were the situations where the adjuvant treatment was considered a standard. Next slide, please. Next. So for those where the neoadjuvant wasn't given, the Zelox and the SOX regimen, the Chinese studies showed a standard of care. Next slide, please. And there was a good data for S1 plus docetaxel, which also improves the relapse-free survival as a doublet chemotherapies if those who are FLOT ineligible patients, nearly 67.7% as compared to 54%. Next slide, please. No effect on the overall survival, even though you see that there is an improved PFS advantage with it, 66% versus 60% with the addition of the S1 as per the Prodigy trial. Next slide, please. The revolutionary treatment came from the addition of the immunotherapies. The nivolumab was given in 577 trial, where the cross regimen was being followed because the trial was started when the cross trial was the standard of care. Next slide, please. And you could see, next slide, please. Next slide, please. All across there was uniform factors that the addition of the adjuvant nivolumab significantly improves the disease-free survival as compared to not giving any therapy. So a nivolumab given for more than a year benefited across all prescribed subgroups in the esophageal and the junctional carcinomas, and became a standard of care across the globe. Next slide, please. And you could see that there was a hazard ratio all to the left that is favoring nivolumab with 40% reduced risk of disease-free of any event in case of esophagus, In gastroesophageal junction, it had a 0.87, meaning a 13% reduced risk of progressions, be it with whatever histology, adenocarcinoma or squamous cell carcinoma, even though it benefited adenocarcinoma more than the squamous cell carcinoma, but again, the benefit was there. 40% with the squamous cell carcinoma benefit and 25% with the adenocarcinoma reduced risk of events. Next slide, please. The PD-L1 expression as is a biomarker was also consistent with this. Next slide, please. The tolerance also, you could see there was, even though the side effects were really comparable, discontinuation due to adverse events with nivolumab is 9% as compared to 3% with the placebo. Next slide, please. So in gastric adenocarcinomas, adjuvant chemotherapy has become a standard key treatment in Asia. In Europe, adjuvant is used when surgery has been performed first, emergency or stage underestimation, post-operative chemoradiation may be discussed in few cases. Next slide, please. Junctional, we use cross regimen and then adjuvant nivolumab in case of residual pathological disease, YPT1 or N1. Next slide, please, with EMA approval. Next slide, please. Next. So when we deal with the esophageal and the gastric cancers, we also have to deal with a lot of supportive care, because malnutrition is a severe epidemiological problem which increases the morbidity in these gastric patients. Proper detection and management of nutritional disorders is mandatory. Nutritional therapy demonstrates a quality of life, adherence, tolerance, tumor response, and survival. The prevalence of the muscle loss and sarcopenia in gastric cancer is high. Sarcopenia is often associated with malnutrition, is often poor prognostic factors. Exercise training intervention is feasible and safe and can be done early, before and after the neoadjuvant treatment. Next slide. And that's where also very important, which has a very important biomarkers. Next, three next. You could see that the circulating tumor DNA has a prognostic factor. When it is detected preoperatively, it's a predictive biomarker for the pathological response. When it is detected at the surgery or after the surgery, it's also associated with significant shorter DFS and overall survival. And circulating DNA is a marker of a minimum residual disease before CT scan. So usually it appears before CT scans by a period of around 6 to 10 months, and therefore ctDNA can be used to guide our adjuvant treatment for most of our patients. Next slide, please. So neoadjuvant, also we feel that the MSI has a very important role, because most of the chemos fail in the MSI and most of the immunos score in MSI. So MSI status is a prognostic role for those patients with the surgically resected gastric cancers, and there is a potential lack of benefit of perioperative chemotherapies with the MSI high status. Next slide, please. And if you could look across all these trials, the MSI is where the responses rates are high with the immunos as compared to the chemos, and that's where immuno checkpoint inhibitors are highly efficient in the MSI high metastatic gastric tumors. Next slide, please. And we have been discussing radiation a lot, but we have to also know that radiation does have a role also in healthy tissues also. So we have to balance that therapeutic ratio. Next slide. Next slide. So there is a very narrow difference between a therapeutic and a toxic effect, and that's why it is important that we maintain that even though the goal of the radiotherapy in GE junction and gastric tumors is to downstage the disease, increase the R0 resections, decrease the local regional recurrence, and improve the survival. Next slide. The distance is something which is, next slide, please, where the cross trial you could see, and also the POET trial where the two combination of the chemos and radiations was tried in stomach cancers. And you could, next slide, you could see that there wasn't much beneficial of addition of the radiation to the systemic treatment, which clearly outlived for it. Next slide, please. And you could see in some cases it was detrimental to add radiation as compared to the chemos. Next slide, please. The New Ages trial.
So sorry to interrupt. Last 3 minutes to conclude, sir.
So you can go to the last slide of mine. Next slide. Yes, so perioperative chemotherapy was not unacceptably inferior to the cross regimen with a 3-year survival rate. The markers of response includes the pathological complete response, major pathological response, nodal downstaging significantly better in the cross arm. There was no statistical difference in the severity of complications or specific index complications or post-operative mortality, hence no negative effect, but yes, the positive effect has been next. An artist 2 trial is which is going to explore in the node positive. Next slide. And next slide. You could see there wasn't much beneficial addition of it. To conclude, a multidisciplinary approach is essential in the treatment of this disease, as what type of treatment, which drugs, what volume to irradiate, radiation techniques, and what type of operations. Next slide. Next. So perioperative chemotherapy is the current standard in the gastric cancers preferred to the adjuvant chemotherapies in Europe. For junctional, 2 options are available: perioperative chemo, that is FLOT, or chemoradiotherapy followed by surgery, and adjuvant nivolumab. Those with MSI high tumors must be identified early because they might not benefit from the neoadjuvant and adjuvant chemotherapies. The prognostic remains in the localized gastric and junctional adenocarcinoma groups. Implementing supportive care with neoadjuvant and adjuvant treatment is essential. That would be the end of my talk. Would love to have any answer if there are any questions. Over to the organizers for a beautifully organized conference so far now.